Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello, and thank you so much to all the team at Spin for the invitation to speak with you today on the neuroimaging of suspected child abuse. Most of the images in this presentation and a lot of the content comes from a recent paper from our group in the ESP, or Child Abuse Task Force, and I'm very grateful to Professor Amaka Ofaya and to Dr. Kishti Mankat for the opportunity to take part in that work. Within the key recommendations in this paper, you'll appreciate that the management of suspected abusive head trauma is different depending on the age of the child. And so in an infant under the age of 1, the appropriate initial imaging protocol is an unenhanced CT with 3D reformats. In a child older than 1, between 1 and 2, we consider CT on a case-by-case basis. And between the ages 2 and 5, the evidence to support CT in this age setting for this indication is low. If the head CT is performed and it's normal, excuse me, but the child has abnormal neurology or there's a high level of clinical suspicion for physical abuse, then they should then go on to have a brain and whole spine MRI, and that should be performed within 2 to 5 days. Now, the level of evidence for this is, however, low. And of course, when we are suspecting abuse of head trauma in the setting of suspected inflicted injury, there are also skeletal and body things that need to be done, such as the skeletal survey and follow-up skeletal surveys. But that will be covered elsewhere and is included in the paper. For the purposes of this talk, we're focusing on the neuroimaging. Unfortunately, inflicted injury is very common. We know that younger children are the youngest of our children, our infants, are at the greatest risk of catastrophic injury. There's a 120-fold increased risk in an infant compared with a child who's above the age of 5. It is very common within the population, with estimates between 14 and 53 per 100,000. And sadly, it is the leading cause of death in infants and toddlers under 2. Now, how do these children present? Well, acutely might be irritable, they might have bruises or oral injuries, subconjunctival injuries, and then as they are more impacted, they may have more serious presentations such as altered levels of consciousness, seizures, and sadly coma or death. In the subacute or chronic setting, they can present with developmental delay or an enlarging head circumference. And throughout this presentation and the cases that I'm going to show you, what I'm going to attempt to do is to try to illustrate the common patterns that are more specific for abuse of head trauma compared with accidental head trauma. And of course, unfortunately, in small children, in infants, in toddlers that are starting to walk, they do tend to have a lot of falls, whether it's that they're sitting on a couch and they fall, or they're lying on a bed and they fall over. So we have a lot of accidental head trauma in this group. And one of the key takeaway messages for everyone is that we're rarely looking at one imaging finding in isolation. We're working with our child abuse pediatricians and putting the complete pattern all together, trying to pick out features that are more suggestive of abusive head trauma or more suggestive of accidental head trauma, and trying to put it all together to come to the right conclusion. Because, of course, the significance of either undercalling or overcalling abusive head trauma is really significant for the child and indeed the whole family. So the most common pattern of intracranial injury in the setting of abusive head trauma is subdural hemorrhage. And the thought behind this in terms of etiology is that classical shaking injury, which, we have this disproportionate heavy head compared to the body in babies and toddlers. And so we know that the neck and the cervical spine is a very vulnerable area. And so because of this shaking back and forth mechanism, that impulse loading with vigorous shaking, the bridging veins that cross the subdural space are more prone towards being torn, and then an associated subdural hemorrhage. Now, when a child, for example, is sitting on a couch and falls off and gets a subdural from a simple impact contact like that, from a simple fall, they tend to be simple. When we have multifocal subdurals, bilateral subdurals, intrahemispheric subdurals. This is more likely to be associated with inflicted injury. But you'll notice I'm not saying pathognomonic or definite. And indeed, later in the talk, I'll be going through some mimics that can mimic abusive head trauma, but in fact are related to other conditions like bleeding diathesis or metabolic conditions. So it's very important to be taking all of it in the overall clinical context and having that multidisciplinary involvement and discussion. Extradural hemorrhages, more likely to be seen with those accidental injuries. In terms of fractures, complex, bilateral, stellate, branching fractures, more frequent with abusive head trauma than with accidental head trauma. But of course, we're back to that positive predictive value that we do also have a high incidence of skull fractures from just the regular accidental trauma that happens a lot in infants and toddlers as they become more mobile. When we do our MRI, however, if we see evidence of hypoxic ischemic injury, cerebral edema, retinal hemorrhages, these are more specific for abusive head trauma. So we're building up that picture of the etiology, putting it all together. Dating fractures, trying to determine if something is acute or acute on chronic, is one of the things that you'll see a lot in medico-legal literature. There's a lot of pressure on radiologists to date things, favouring an acute subdural hemorrhage if we have the sedimentation of high-density blood products, if we can see high-density hemorrhage. But we would advise that we shouldn't be trying to date abusive head trauma on CT density or MRI intensity, but again, putting the whole picture together to come to our conclusions. If we move on to the spine, very important to pay very close attention to that craniocervical junction. I've mentioned earlier that's a very vulnerable area in infants and toddlers. And so when there's a shaking injury, they're very prone to getting ligamentous injury. So including a fluid sensitive sequence is looking closely at those ligaments. Look for fractures, look for subdural hemorrhages, very similar to what we look for in the brain. And again, these injuries more associated with abusive head trauma than with accidental trauma. With this paper, what we were really trying to do was provide a primer and an introduction to inflicted trauma for trainees, for fellows, for general radiologists who might not have much exposure to imaging of child abuse. And what we wanted was something that could be on people's desktop or in their library to be pulled out and used as a reference. And so with that in mind, we have gone into a lot of detail around the common injury patterns and review areas to really try to help people in terms of confidence around reporting. So obviously you're going to look at everything, you're going to look at all your 3D reconstructions, but it's always helpful to pay specific attention to the review areas that are high yield for injury. So the parietal skull is the most common site for fracture in abusive head trauma. In the parafalcine region, if we see a subdural hemorrhage, that's much more associated with abusive head trauma than accidental trauma. Pay attention to the bridging veins. Again, we mentioned that vigorous shaking that can cause shearing injury to the bridging veins, especially where the bridging veins are meeting the superior sagittal sinus. So now we're going to move on and we're going to discuss some cases. So you'll see here on the left, I have an axial CT image on bone windows. In the middle, I have 3D reconstructions, and on the right, I have the same level, but it's the parenchymal window. So you can see here that we have a minimally depressed left parietal fracture, very nicely seen on our 3D reconstructions, and very different to the normal pattern we see with the sutures, the appearance of the fracture. And then on our parenchymal windows, we can see that hyperdense left parietal hemorrhagic contusion. And here you can see, again, in this same 12-month-old, the MRI findings at the same level. We have an axial T2, a susceptibility weighted image, and the ADC. And so all three of them demonstrate the contusion, but we can see that the susceptibility artifact related to the hemosiderin blood products much more pronounced on the SWE, and I find myself the SWE is a very useful sequence, especially for looking at those bridging veins and looking for injury and shearing injury and blood products related to it. The next case is an 8-month-old baby boy. He presented to the emergency department floppy and unresponsive, and his carers were unable to give any reason for this presentation. You can see here on the unenhanced CT that unfortunately there's multiple bilateral subdural collections. They're of mixed density, some intermediate, some high. There's also some parafalcine subdural hemorrhage on the Colleran fluid attenuation version recovery sequence. And then we also have our B1000 and our ADC. And so we've got some susceptibility, which was related to the in situ intracranial pressure monitor. You can see that we have a hypoxic ischemic injury. And here we have those torn, thrombosing, bridging veins, showing that signal hyperintensity here on the coronal flare. And so all of this painting up the picture. So we have parafalcine, we have multiple subdurals more likely to be associated with abusive trauma. We've got hypoxic ischemic injury, we've got injury to the bridging veins, very much a picture that's associated with inflicted trauma. This is that same baby, and this is their spinal MRI. You'll remember that we talked about the cervical ligaments being very prone to injury, and here you can see that ligamentous injury in the cervical spine, that high signal on the fluid sensitive sequence, and also a subdural hemorrhage in the lumbar spine. Now that I've shown those classic injuries that are more associated with abusive trauma and gone through those review areas, I'm now going to show some mimics. So you can see here that we have an axial CT on parenchymal windows, and we also have an ADC map, and we've got a parafalcine subdural hemorrhage, and we've got hypoxic ischemic injury. But this isn't abusive head trauma. This is a girl with factor VIII deficiency who's encephalopathic. So again, coming back to, yes, we have radiological findings that are more associated with either abusive or accidental head trauma, but the clinical context, the history, that collaboration with our child abuse paediatrician colleagues, so important for making the right diagnosis. We have here two images from a flare, axial flare, from a little boy, and you can appreciate here we have our right-sided subdural collection, but I'll draw your attention here to the insula, and you can see that there's under-operculization of both insulae, and this, as I'm sure many of you have already recognized, is a boy with underlying glutaric aciduria type 1. So again, know your history, know your prior investigations before embarking potentially down a wrong path when being caught out by a mimic. This is another axial unenhanced CT on parenchymal windows, which demonstrates subdural collections. And then on the SWIHI, we can appreciate these punctate areas of microhemorrhages. This was a child with severe pneumococcal sepsis. Our next patient, we have axial unenhanced CT images on parenchymal windows, and we can see this hyperacute extradural hemorrhage. There's also a skull fracture. There's also subdural hemorrhages. There's some subarachnoid blood, and this was following trauma. Another mimic, this is a neonate, and we've got a sagittal CT on parenchymal windows and a 3D reconstruction. And so this hemorrhage is likely parturitional subdural hemorrhage. This is a neonate. This neonate was known to have osteogenesis imperfecta. You can appreciate that there's multiple wormian bones. So again, knowing the history, the clinical examination, the investigation, so important to put them all together. Our last case that I'll show you then in terms of mimics, this is another child with osteogenesis imperfecta, multiple vertebral body fractures, and also a post-lumbar puncture spinal extraaxial collection. So history is key. Before we finish up, I'll go on now to briefly discuss what pertinent positives and negatives should be in our reports. So in our CT, very similar to our key findings and our review areas, we need to document the presence or absence of a skull fracture, comment on any parenchymal swelling or injury, whether there's any hemorrhage present, specifically a subdural, any subarachnoid, epidural, subpial hemorrhage, and any focal parenchymal lesions. It's very hard to date subdural hemorrhage on CT, and we should try to avoid it on the initial CT. It's really important to mention at this point that cranial ultrasound is inadequate for clinical use in this setting, and actually using it can be falsely reassuring, so we didn't include it in our flowchart from the ESPR task force. And a critical thing that I hope I've been emphasising throughout this is that involvement with the child abuse team for their assessment and their discussion. is all so important because this very much needs to be managed in a multidisciplinary fashion. Similar to our CT, the MRI is very similar. We need to document in the brain and spine if we have any evidence of subdural hemorrhage, things that are different. Are we seeing any focal or diffuse hypoxic ischemic injury, because we have the added benefit of having our diffusion, and the parenchymal injuries that can be quite subtle, some of which mightn't be seen on CT but will be picked up on MRI, contusions, clefts, and of course using our susceptibility weighted image to look for microhemorrhages, interrogating those bridging veins, looking for thromboses, looking at that craniocervical junction for any injury, vertebral body fractures, retinal hemorrhages, and again, documenting all of this. This is the flow chart. It might be hard for you to see on this projection, but hopefully we've given a really good roadmap for the infant under 1, the toddler between 1 and 2, and the child older than 2, of what neuro investigations are most appropriate. And of course, that changes depending on whether they have normal or abnormal neurology and how high the clinical index of suspicion is. I hope that you found this helpful. I'd be delighted to hear from any of you. This is my email. And again, great thanks to all my Child Abuse Task Force colleagues, led so ably by the brilliant Professor Ofaya. It's a wonderful opportunity to get to talk to you today and to be part of the worldwide team at SPIN. And for those of you starting out on your journey with this, keep going to talks, keep collaborating, keep learning. It's a lifelong journey for all of us, and we're all in this together. And thank you so much again to Kishti and Osgur and all the team at SPIN.